All right, good morning, everyone. It's a pleasure to be here, and thank you for inviting me. Ottawa is my hometown, so I well know the end of November weather, usually. I also trained at this hospital, as an intern, when there was such a thing as rotating internships. It was a year or two ago. The building where I used to sleep overnight is still there, I noticed. So I became, I've been doing geriatric psychiatry for a long time, for about 30 years or more, and I became interested in caregivers, of course, as we all do, because it's obvious and has always been obvious that when dealing with dementia, caregivers are essential. It started to become clearer to me, however, in the last few years, that we need to do better in our understanding of caregivers and in incorporating the concepts of care around caregivers into our approach to diagnostics and treatment of dementia. We do pretty well at this point in uncovering dementia in our memory clinics and so on, but caregivers are often, and I would say generally, a bit of an afterthought in terms of getting collateral information, or maybe getting referred to to a social worker or to an Alzheimer's Society local program for what we call support. And these things are important, they're critically important, and I'm not in any way devaluing that, but I think we can become somewhat more refined in our understanding, and it's my hope that we can talk a bit more about that today and look in a little more depth at this whole thing. So I've characterized this as the caregiver-patient dyad as the unit of care, and I'll tell you what I mean. Now, advancing these slides. Okay. So I'll just look a little bit at the background of caregivers very briefly, and then focus on the dyadic model, with an emphasis on the caregiver side of that model, since that's where I think we might need a little more emphasis, and time permitting, talk about some intervention models. Canadian caregivers, if you've looked at this at all, you'll be familiar with this. Most dementia care happens in the community, both in the US and in Canada and other jurisdictions around the world. 3/4 of the care is provided by family members, and of these, the majority are women, and often older women. Half of them are in the geriatric age range themselves, and many at an advanced age. And caregivers, particularly those who are living in with somebody with dementia, and that's very much the focus I'd like to look at today, this is an at-risk group. Depending on what stats you look at, roughly double the rates for depression, but also there's a 60% increase in mortality rate in this population, and the reason is that caregiving is a chronic stress state. If you look at stress-related factors, immune factors like interleukins or tumor necrosis factor or cortisol, these things are all elevated in caregivers. And thankfully, there's some data that suggests that with intervention, you can actually reduce these stress factors. At a more human level, one of the caregivers was talking about what it's like to gradually evolve into this state. And she said it's like that story of a frog in boiling water, that you don't really realize what's happening. It just gradually creeps up on you until the water is boiling around you. If you're not humanistically inclined, you might be economically inclined. Caregivers, if they were to be replaced, would go a long way to bankrupting our healthcare system. $25–30 billion in 2009, much more now probably, and that's true in every Western jurisdiction in the world. So who are caregivers? When you think of it, you have images of, obviously, that come to mind from your work, But I would say that this is not as obvious a question as it may seem. If you look in the dictionary, it says caregivers are somebody who are caring for somebody who it's variously defined, but somebody who cannot look after themselves and require assistance. And that's kind of the bare bones of things. And in some ways, that's the way we have characterized caregivers. That is, as an addendum to the illness itself, the illness process, whether it's dementia or anything else. What I want to do today is reverse that lens and look at this whole thing from the perspective of the caregiver themselves. So why is that important? Because in this very large population, if we're talking about dementia care, then every person with dementia has at least one caregiver. When we think of that side of the equation, we do it from the perspective of, I think, the professional understanding of the disease process. And when we do that, I think we often end up with a mismatch between the way we develop interventions for dementia and for caregivers and their needs. So if we see caregivers in the way of being instrumental instruments of care for dementia, then our interventions for this dyad will also be instrumental. And that's largely been the way that we have addressed this issue. If we don't do that, then we come up with, I think, different understanding. Family members, when you ask them who they are in this process, don't identify as caregivers. In fact, in our work, in reaching out to caregivers, when we characterize our outreach as programs for caregivers, people don't resonate with that very well. They see themselves as a husband or a wife or a child, and they are doing what they need to do in order to engage with their father or their mother or more commonly, their husband or wife. The definition is more than semantics, because if we redefine it, then we start to redefine the range of needs and the reasons that caregivers experience burden and why they are so stressed in this process. It's not just that they don't sleep, it's not just that they have to do things all the time. There are factors that impact on caregiver burden that need to be taken into account beyond that. So this is an example of a younger person. I think it highlights the complexity of the caregiving situation. This happens to be a daughter, but the nature of this, of course, could be anybody. I've disguised this naturally. But Joan is a 52-year-old single daughter who lives currently with her mother. She's been in our program in Toronto. Her father died about a year ago, and she gave up her job in order to move in with her mother, who was around the same time diagnosed with dementia, probably because her father was covering for her mother and they could get away with it. When he died, she was kind of uncovered as a person with dementia. Trouble is, as is often the case, that when she moved in with her mother, she got a lot more than she bargained for. It wasn't just that she was looking after her, but she had to deal with this significant array of behavioral disturbances, PTSD. She also was saddled with the whole burden of it because her two siblings who live out of town with their own families saw her as being unmarried, and therefore she was it. She was going to have to do it. And her life became submerged in this whole situation. And she talked about how painful it was for her all the time. And this seemed to be one of the highlights of what she was struggling with, the pain of listening to her mother calling out from her room, "Is anybody there?" she couldn't stand the feeling that her mother was suffering in this way. And she was just preoccupied with it, and it reverberated with her own history of depression. She had a major depressive disorder, had been treated for it for a long time, and there were all kinds of other issues that she was struggling with. So why do I tell you this? This is not such an uncommon story. You've encountered it many times. It's to try to highlight the complexity of the issues that start to emerge in caregiving situation. What happens to the individual's life? What happens to their identity? What happens to their work, their ability to earn a living, to their own recurrence of psychiatric problems, and so on. Most of this stuff remains relatively invisible to the healthcare system unless we go after it. So when does a spouse or a child assume the identity of caregiver? It is, in our experience, when the communication process is damaged to the point that the partnership in the relationship is lost, where there is no longer any joint decision-making, and as somebody said, I'm not his wife anymore, I'm now his caregiver. But it's a transition state to become a caregiver. For a long time, it's not that. The transition occurs gradually and is associated with a lot of psychological challenges naturally. Here are some of the things that have emerged as we've understood caregivers with some more depth. One is adapting to an impaired partner. Here I'm talking about spouses, but children who are live-in experience similar things, although not in the same way as the spouse. There's an undoing of the relationship. This includes role reversal, of course, taking on things that never had to be done before. Women who didn't have to manage the financial side of things. I don't mean to be sexist or stereotyping when I say that, but it is commonly one of the things that people say. And solo decision-making, thinking for two all the time. So it's not just thinking for yourself and having nobody to talk to, it's also having to think all the time about the other person and making decisions for them in the presence of the absence of a confidant and lost companionship. There are intense emotions, of course. Dementia is a guilt-inducing disease. It's a bottomless pit of need that someone has. It's always something that has to be done, and as a caregiver you never can do all of it, and so you're always disappointing and always unsure. It induces anger and frustration, and of course anxiety about the future. What's going to happen? What's going to happen to him or her? What's going to happen to me? Depression, and also shame in living with this disease. People don't like to talk to others about their living conditions. There's isolation. We talk a lot about it, but what people talk about actually is not just not having engagement with people, but rather the feeling that even when they are engaged, somebody said to me this week, Tuesday, that she goes out with her friends, because I was asking her about self-care and so on. She goes out with her friends, but when she's out with them, she feels alien, that what's going on inside her and where her mind is and where her sense of being understood is, that just doesn't resonate with them. So this is a hidden but very intense state that caregivers experience a lot. Similarly with family. Loving family doesn't necessarily understand, and caregivers talk a lot about the comfort of being with others who are doing the same thing, because no matter how much others, family and so on, are around, they don't really get what it means to be there 24 hours a day, engaged in things. There's an unwelcome new self-perception, don't know what the future is going to be, they're trapped, bewildered, and so on. So the emotional challenges are intense, and I highlight them because I think that while there are lots of instrumental issues, I think that the emotional issues are often the rate-limiting step in the capacity of the caregiver to be able to carry on. And so I just pay some very specific attention to that. If we are going to think about caregivers as part of a diagnostic process, then we have to have some approaches to assessing caregivers. And our nosology and organizational or diagnostic structures really don't yet have instruments to address this side of the dementia equation. People are working on it, and there are quite complex research-based instruments for assessing caregivers, but we don't have clinical assessment tools the way we do for dementia. So I would like to propose to you, to come back to my theme, that if we're going to diagnose dementia, then we need to diagnose the dyad, both sides concurrently. And I put up this picture thinking that everybody would know what it is, right? The care recipient dyad goes together like a horse and carriage. And then I thought, I wonder what the generation of people is in this room, because not everybody will remember that old song, Love and Marriage. Even that, love and marriage go together like a horse and carriage. Forget it, right? Tell my son. So this is the very general paradigm, right? There's an index referral. It comes for some reason or another. But I think our challenge is then to look at the family caregiver and the patient with dementia concurrently, to use diagnostic approaches, and I use that advisedly, that medical model, but to have diagnostic approaches in the process from the beginning that incorporates both sides of the equation, and then to develop a comprehensive integrated management plan, which cannot just be for the dementia illness itself. I mean, we know what we can do with dementia, right? Not a whole heck of a lot yet, regrettably. We're still in the pre-treatment phase, in a sense, for dementia. And so most of our interventions are going to be mediated through other ways, and it is interactive and engagement strategies that are at the core of dementia management at this point. That means the caregiver. So I would suggest then that a systematic assessment, and by the way, I'm not suggesting that in a busy general practice everybody's going to do this, but these are conceptual models to think about. The first thing is to identify the stage of caregiving. Where is this person in the continuum? And on the basis of that, to assess their needs and to look at key factors that are specific to this caregiver care recipient dyad. These are not general rules that need to be put in place, but specific to this particular set of issues. And out of that, to create a management plan which, again, responds to defined problems with specific interventions. So what often happens with dementia care is that the person with dementia gets some focal intervention. There is perhaps some instruction for the caregiver, but it's often very general instruction, what to do with, I don't know, if you go to a class on dementia, you will get a competent, presumably, discussion of what happens as a result of dementia and what can be expected by the caregiver and what to do. Look somebody in the eye, talk slowly, don't use a lot of words, all of those kinds of instructions about how to communicate, what to do with aggression, and so on. What caregivers struggle with when they're trying to implement a treatment plan is what's relevant to them. And they don't know that. So all of these general things need to be translated with specificity for them. And it's complicated because it takes time. So let me talk a bit about the stages of care. I said that it's a slowly evolving process. I'm going to be focusing here in large measure on the live-in caregiver. That's where the greatest degree of stress is. It may not be where the biggest numbers are. We've got a big project looking at generally children who are employed in the workforce, and if I have time I'll tell you about it. But children are often care managers. That is, they are hovering over the system and trying to make sure that everything is okay at home. The person who is living in is at the highest risk and in the greatest need. I know this is obvious in some ways, but it bears speaking about. Okay, so I've divided caregiving into 3 stages. And the reason for staging it is that the needs for intervention are different at each stage. So caregivers are not caregivers are not caregivers. Where they are in this process determines what they're going to need. In the first stage, the diagnosis has been presumably given. There are complications around giving a diagnosis, but aside from that, it poses an uncertain future for the caregiver. They start to adjust to this new information. What does it mean? Where are we going? And over the first period of time, and it can go on for 2 or 3 years, they're hoping that the worst won't happen to them. They know, they're told, right, this is going to get worse. But it is quite common for them to say, well, maybe it won't get worse for me. And so they're somewhat anxious about that. The relationship changes, however, are relatively mild, and by that I mean that the core of the relationship remains, and intimacy and caring for one another are still possible. Communication remains relatively intact. There are some nibbling around the edges, more repetition perhaps, having to provide instructions a little more firmly, and so on, but overall communication remains, and as does independent activity. So from the caregiver's perspective, what this means is that they can go out and leave this, their husband, their wife, alone. They're not worried. The safety issues are not of a major concern for the caregiver. So their independence remains. They don't need a lot of help for themselves in providing activities of daily living support. So the instrumental activities are probably not as good as they were before for the person with the disease, but from the caregiver's perspective, they have to nudge the ship without actually taking it all over at this stage of the game. Coping is generally adequate for them and for the person with dementia, and at this stage, they don't need a lot of additional help. So I don't have data on how many people are in this stage of caregiving as opposed to the more advanced stages. But when we think about the caregiver population, I would say that in terms of developing interventions, what we need at this point is less emphasis on some of those core things like helping with system navigation or getting help in the home and so on, and more on helping this caregiver understand what it is that's happening and how to begin to prepare for the evolution. Second stage is the one that I think we're most familiar with. Here, the caregiver has generally understood and accepted the diagnosis. They're not thinking that it's not going to get worse. They can see what's happening, and every little change starts to really hurt them because they can see that it's getting worse. They see the impact and meaning on life, and their uncertainty about whether the disease is there is gone, but their uncertainty about the future starts to build. The relationship is significantly impaired at this point, and so the caregiver is gradually evolving into a new state. And it has a lot to do with the fact that communication is damaged by the very nature of dementia, almost universally. So it becomes intermittent or absent, and one wife said, "I forget what love is like," because she just no longer gets the response from her husband. Rachel Haddad, who's an author, said the silence was the worst. This was her experience. The silence was the worst. Silence not as in solitude or concentration, but as in living with, eating with, waking up beside someone who has nothing to say to you. So when we talk about what happens in caregiving, this is the silent internal transformation that occurs. The responsibilities for the caregiver evolve. So joint decision making is gone. And all duties at home now have to be focused on, decided upon, planned by the caregiver themselves. And it's everything. It doesn't matter what it is, whether it's what we're going to eat tonight, or where we're going to go in the morning, or how to get to the doctor, or the travel plans, or what time we have to leave or wake up. Or one woman in our group this week was struggling with how she's going to make sure that her husband gets fed and will eat, and at the same time get his insulin, and she was just struggling with this responsibility of these kind of life and death management issues, because she just didn't know. That's one thing, by the way, in caregiving. The person with dementia who also has concurrent illnesses that have to be treated by the caregiver requires significant additional help, because the reliability of the caregiver being able to actually do things like ensure that diabetes is being treated properly, or medication is being given, or blood pressure is being monitored, or whatever it is, each of these things becomes problematic. The independence of the caregiver is damaged. There's supervision with all or many ADLs, dressing, eating, toileting, and it becomes very intimate and often noxious and unpleasant. And this is the point at which the caregiver starts to feel trapped at home, and as someone said, I can't plan without him. Anything I do, if I want to go out to Starbucks for half an hour, I have to plan for him at the same time as I plan for myself. And this isolation starts to develop. And it's at this point, this is where the need for additional services becomes necessary. Now, I know that's obvious in the individual case, but from a systems planning perspective, we haven't really begun to thought about this. We've got these great big statistics about 750,000 people with dementia in Canada, and 750,000 caregivers, or 1 million, or 2 million, or whatever the millions are. But when we start to plan services, where actually are things needed, and what's needed at which stage? So this is where system navigation becomes important, because this is the point at which the caregiver is starting to seek help. Stage 3, I've characterized as overwhelmed caregiving, terminal caregiving. What does this mean? This is a transformation. This is the point at which the caregiver is no longer saying, I'm able to do this, I can manage all of this. It is a recognition that the caregiving process has now reached its limit. The diagnosis is not anymore about dementia. How do we treat dementia? Right? We see a patient, we say, come back in 6 months, and we do a mini mental state, or we track something, or in a memory clinic, it even might be much more extensive testing. And that's all fine. We want to see where the dementia is going, but actually it doesn't address this issue at all when we do that. It doesn't translate into all of this that I'm talking about. So what then becomes important in this stage of caregiving? The caregiver is concerned less about the disease. They start to say, well, what's the point of going to the memory? It doesn't matter. Right? The medications aren't doing much. I'm having to manage this. It doesn't matter what the score is anymore. They're concerned about the concurrent problems. They're concerned about weight loss and frailty and concurrent illnesses. And they don't know what to do about these. When you get to this stage, they start to wonder, what do I do if something happens at home? If I have to call 911, what do I tell them? Do I tell them not to do anything? Do I put a DNR envelope on the back of my front door as they request, and so that they know not to do any resuscitation? Do I send them to the hospital? What do I do with these illnesses? Do we treat them? Do we not treat them? So if anything happens, the caregiver is left in a real dilemma about what to do, because this disease, they know, is only going to lead to a terminal state. The relationship here is completely fragmented. There's intense isolation. And here there is the feeling that their partner, husband, wife, parent, has died, but the body is still alive. And that's where this phrase disenfranchised grief comes from that you've heard. So this sense that they can't give up on the one hand, but they have to give up on the other. If you haven't had to go through this, it's a good thing. But it's very tough to understand this living death state of the caregiver. It's no wonder that the stress factors go up. Communication is infrequent, largely absent. The decisions are all a responsibility of the caregivers, and they're now life and death decisions frequently at this stage that have to be made. And it's not whether to take out a breathing tube in the ICU when somebody's comatose. This is somebody who is still alive, still functioning to some degree, and so the decision is agonizing. Here is when caregivers are overwhelmed. I mean, they can get overwhelmed at any stage, but this is where the caregiver is feeling overwhelmed, and things come up. For example, how am I going to get out of this? The only way I'm going to get out of this is if he dies. And that's a pretty bad feeling to have for somebody you love. And if you don't happen to love them, because not everybody loves their loved ones, then that feeling induces this great conflict that has existed the whole of their life. Right? If I could get rid of him, I'd be happy. She might have thought 30 years ago and didn't. But now, to feel that when he's completely dependent on her is a whole other kettle of fish for the caregiver. There's no independence. They have to be fully replaced at every stage if they go out. And this feeling of entrapment is profound. Role entrapment, by the way, you can measure it. And role entrapment is one of the most important factors in the creation of caregiver burden. Help seeking is now, I mean, things have to be done at home and all of that, but the caregiver by this stage usually has a lot of things in place. What they're now struggling with are placement decisions. How do they make this decision? And when do they do it? And so on. These are transformational, emotional and psychological issues. I think, interestingly, I made this up. I don't know for sure if it's true. But I think it's at this stage that we become much more concerned about the welfare of the caregiver. Because we can see clearly now that this whole thing is falling apart. The system can't carry on. The caregiver is overwhelmed. And this is where the caregiver maybe becomes the object of concern themselves. You can tell me whether that fits with the way you see it or so on. But so if we're going to evaluate the caregiver, what kinds of things do we want to do? The domains of assessment include these. It's not the whole story, but there are things here that I think we don't usually do with the caregiver themselves, so I've highlighted them. We need to know the medical state of the caregiver, their physical condition, because that too is a determinant of, one of the highest major determinants of risk for decompensation in the caregiver. I don't know how often, if you've assessed somebody with dementia, that you actually talk to the caregiver about their medical state, their illness history, their medications, and so on, and incorporate that into thinking about the management plan. Psychiatric history is no-brainer. We know that's important, especially depression, but other things as well, because these stress states will re-evoke long-standing psychiatric problems. The current support structure really requires the assessment of the presence of and also the adequacy of instrumental support. That we do not too badly often. Not that we provide it, but that we know it's important. Professional support. Who's going to actually respond to the caregiver? Because already you can see the array of questions that the caregiver is struggling with as they're implementing the management plan on a daily basis. So what kind of psychological support might they need? Some need more than others. What kind of medical professional backup do they require? Is once every 6 months sufficient? Right? Come back in 6 months. It's a slow-moving dementia disease. If we're focusing on that, we don't see people frequently. But what does the caregiver need in this process? That's a different question. What's the social and support structure? And this is not just the presence of people, but the perception of the caregiver that they are receiving support. So it's perceived support that's important. And especially confidants. Caregivers often, even those who are experienced already for years, don't really understand the disease commonly. And they have distorted beliefs and emotional reactions to the disease, especially behavioral disturbances. And one thing to take into account, and again, I know if you think about it even for a moment, culturally determined beliefs are important in this. What is the meaning of dementia? What is my role in this process? What is my obligation as a caregiver, and so on. The caregiver-patient relationship is critical. Caregiver burden is elevated when there has been pre-existing conflict. Well, really. Of course that's the case, except that understanding the nature of that conflict is important because it helps to determine the way in which the caregiver is going to be approaching this process of looking after somebody. I'll come back to that. But past conflict and issues in families are very common, and they affect the management of dementia when it emerges. And it's not just figuring out, is the family working together and so on. It's a much more intimate inquiry that will really tell us what's happening as a result of this long-standing relationship strain. So in an attempt to crystallize this a little bit, I've created a checklist for caregiver assessment. I hope it's not repetitive of what I've just said, but here are the questions that I think may be useful in a practical way. Does the caregiver feel that the diagnosis has been clearly established, and has it been told to them in a way that they understand? It often doesn't happen. Does the caregiver accept and understand this diagnosis? It's remarkable to me how often caregivers have been told what's going on, but they either don't get it or they don't believe it. Well, I know he has dementia, but he's doing it on purpose. I know he has dementia, but I don't think it's really going to get worse. That kind of perspective. And so no matter what you do professionally in terms of trying to implement a management plan, you're going to run into a barrier if that's not addressed. Does the caregiver accept behavioral disturbance as involuntary, or do they blame the person? This is a determinant of caregiver burden, believe it or not. The more they believe that the behavior is willful, the heavier the load is for them. What is the caregiver's level of knowledge about the disease? Of course. Do they have realistic strategies and skills for dealing with BPSD? So all caregivers come into this relative novices. They don't have skills and training. We train professionals to do this, but caregivers who have to provide 97% of the caregiving time don't have any skills training. That's what our program is about. It's both skills training and cognitive training. I'll tell you about it later maybe. Does the caregiver know how to access and use professionals appropriately? This is not just PSWs or the CCAC. It is also the physician and what to do with the memory clinics and how to manage that whole process, as well as the emergency department. What do I do if I have to go to the emerge? And how do I manage that? What are caregivers' beliefs? Cultural, we've talked about that. What is their level of emotional resilience or vulnerability? So this is a caregiver assessment itself. Who are you? How do you handle problems? How overwhelmed have you been in the past? How overwhelmed are you now? Our Lady Joan, who had a long-standing depressive disorder, had a lot of trouble. Not just because of the role she was playing, but because she was trying to handle her own internal state. What's the history of the relationship? So I said before, it determines our understanding of this. Caregiving that's given out of love has one set of impact on the caregiver. Caregiver that's given out of duty, I have to do this because I'm his daughter and that's my job. He was always a son of a bitch, I quote, but it doesn't matter, I have to do it. Or, he never looked after me, why do I have to look after him? And you get this kind of subtle abandonment by the caregiver. Or is it just resignation? Oh, I'm stuck, I gotta do it. And finally, this perception of adequate social support and the caregiver's physical condition. It gets left out of our assessment process routinely unless they get sick and go to their own doctor. But the caregiver often has their doctor, the person with dementia has their doctor, and never the twain shall meet. So it's worth thinking about. Okay, what helps? So we've defined the problem. Can we do anything about this? I would say if we're going to set up systems of care that incorporate the caregiver, those systems for the caregiver need to be evidence-based to the extent that we can. We have a lot of evidence about what caregivers need. They need to be specific, and they have to be brought to a large scale. So our task is to have general principles that are specific at the point of care. That's true for all of medicine, but it's especially true in this kind of system development of care. Most of the interventions have been research-based rather than clinical programs that are embedded in the system, but there are some. This review surprised me, actually. There were 41 caregiver intervention programs that had been tested with randomized controlled trials. This was in 2005. There are more now. And interestingly, there are important principles that have come out of this. So if you're thinking of deepening your caregiver program development, then here are some principles that have been found to be effective and necessary. Caregiver programs are most effective if they're multi-component. Psychotherapeutic interventions are effective. CBT-based things have been demonstrated, but I think any kind of formal psychotherapy is helpful. They need to be specific and tailored to the needs of the caregiver and of adequate duration. So quick and dirty, one-shot education, lectures, and so on. These things are not going to change very much. Education by itself, if it's done in a sequential way, can help improve the behavioral state of the person with dementia. In other words, if you hone your treatment instrument, the caregiver, by educating them, they will do better in managing dementia. But it doesn't help them, and that's been demonstrated. And you've got to go long enough. 6 months seems to be one of the benchmarks. I would say that planning has to be for the duration of the illness, and what to do has to be thought through carefully. It's got to be of adequate intensity. Quick and dirty doesn't work, and it has to address the dyad. The most effective programs are those that incorporate an understanding and management of a person with dementia together with the person together with the caregiver. So most of our programs are split and separated. We do these things in two solitudes. I won't go into this now. So the good news is that well-constructed programs are actually effective. They improve caregiver burden. They actually improve those physiological markers. And they reduce service utilization, and they can delay institutionalization. I wouldn't bet the farm on that data, but I think it's an indicator that we need, if we do better, then we can have better outcomes. Okay, I've just got a minute to talk about the center. The Reitman Center is the center that was developed at Mount Sinai Hospital in Toronto. I think it's the only one in Canada, maybe in North America, maybe anywhere, I don't know, that's actually embedded full-time, devoted to caregivers in a healthcare institution within the healthcare system. And it was very specifically developed for that reason, because this is not just a social issue that needs to sit off on the side where we do good works in the community. this is something that needs to be part of the healthcare management system, because you saw the data. If we don't do something along these lines and manage caregivers effectively, then we don't have a treatment instrument right now. If we don't have a treatment instrument, then all those $35 billion of effort is going to have to be provided somewhere else. And we don't have that money or resource. So what did we do? Very quickly, we took all of that data and on an evidence-based basis, we created a program that embodies all of those principles: psychotherapeutic, intervention, intensity, duration, and so on. We developed a 10-week program. It's a group-based program, small groups, because they need to be specific for the needs of each caregiver, 6 people in a group. We have trained group leaders who incorporate 2 approaches. One is a CBT kind of approach using problem-solving therapy, PST. So we've adapted that to the caregiver. We don't call it therapy because in a way this isn't. It is problem-solving technique. So we teach that in a 10-hour course. They call it a course. It's actually a group therapy environment. We also have a 6 session, it's about 15 hours of simulation training. So we have trained, standardized patients who play the part of the person with dementia in the group. The caregiver and the person and the simulated patient sit down and they say, my husband got very agitated this week because this is what happened. The SP says, what did he say, how did he behave, what did he do, and then enacts the role. The caregiver just does what they did, and so we ask them to enact it together. When they do that, the group leader observes what's happening, looks at the interaction, and looks at both coaching a change in behavior, but also coaching around the emotional reactions and so on. These can get quite intense. It's interesting. So in this process, we address problem solving, communication, management, and the emotional underpinning that the caregiver is going through. All of these things come up in the course of these sessions, and the intervention is both, I would say, both therapeutic and instrumentally skills training and skills building. So my time is up. There's a lot more to say, but I thank you for your attention, and I'm happy to answer questions.